So while we're gathering, let me just tell you what this event is about, or this part of the event is about. In April this year, I think it was, I went with Declane Kirrane, who, as you know, runs the Science Summit. And I went to Washington, D.C., for two reasons, actually. A, because I'd never been at a World Bank spring meeting, and I don't want to go to another one. Dull and boring, and same people talking to the same people, and the only thing they ever agree is to do the same thing again at a certain date. So I was bored, but I learned a lot. I went to different sessions on finance, on health, on science, economic impact. They all are great people, all doing wonderful work, but they all use their own language, their own acronyms. I went to one meeting, I'll have to tell you, for 20 minutes, and I had no idea what anyone was talking about. Everybody else in the room knew what everyone was talking about, because it's like an echo chamber. So later when we gathered everyone together, I was asked to give my views, and I said, you're all doing great work, but it's like you being on 4 different freeways, 4 different autobahns, whatever you want to call them. There are no interchanges to get across to another freeway, because you could die in the attempt. So since then, I decided, and with the group in the Global Health Connected, that we had to do something about this, because the world has changed, fundamentally changed. Not just because US aid was cancelled, which is has a huge impact, but because the whole thinking there's much more selfish attitude these days among nations, as we probably gather. That's why the world is in such turmoil. So we decided to do it in our own little way, do something about it. So this morning's panel is about looking at how can we make real, the collaboration or collaboration, as Richard has taught us to say, between these 4 sectors, let me call them that. What we're doing today is not to debate that, but actually to give, I hope, some real life examples where convergence already exists. Because as Bletton said, stories are much better than blah, blah, and we're gonna. We're not interested in the we're going to. We want to actually do something. And to make real things happen, you've got to have some specific examples of where it's already happening. So we have a couple of those this morning. I'm not even going to introduce the panel. You've seen their names. Even if you don't know them, they're going to tell you in 2 sentences who they are. But more importantly, I'm asking them to tell us what have they done about this convergence. And I should declare my interest. First of all, both Raj and Phil are actually Global Health Connector partners on our council. So I know some of the answers they might give. Our other strategic partner is GSMA, represented here. This is the first time at one of our events that GSMA have been here, and we have a global partnership agreement with the GSMA organisation. So I'd be really interested to see what have you done about convergence. So I'm going to start with Phil, and off you go.
Thank you, Brian, and always a pleasure joining you and Raj and colleagues on this stage. The question is, what is convergence? But I feel like it's like everybody knows the answer, so let's talk about examples. But I want to reflect a little bit on the question. So the convergence between these 4 sectors that are extremely important, I see it at both national or sort of public health system level or public level, then individual level. At the national level, my background is public service. I currently serve as a Chief Digital Advisor at the Africa's Centers for Disease Control and Prevention. Previously, I was serving in the government of Rwanda as Minister of Information Technology and Youth in Rwanda. So convergence starts with people talking to each other and sectors talking to each other. There was a period of 10 years where our colleagues at GSMA always said, ministers of technology, you need to be speaking to ministers of health, you ministers of finance. And that conversation was not happening. And even up to this day, there are countries and places where this conversation is not yet fluid. So at that level, when convergence happens, you realize that everyone has a piece of the problem and then a piece of the solution, and it's almost like a puzzle. And the only way for the solution to be built is everybody bring their piece together and you find the right arrangement, and then you can construct a solution. But even if one piece is missing, you can't build a solution. So that's a convergence at that level. But at the individual level, I think the question on who has their health record in their pocket, and 50% of the people in this room, ask the same question in a country in Africa, you will see the proportion will probably be 1% or even less than 1%. But ask the question, who has access to their financial wallet? It's almost like 90%.
Yeah.
So the convergence is not yet happening because people, like financial inclusion has moved far ahead of health inclusion. And I think asking this question today is really important. But then what are we doing about it? And so I'm getting to your question on examples. So I'll talk about two things that are happening simultaneously, but also separately in Rwanda and in Kenya. In Rwanda, the government just launched in the month of May something called the National Health Intelligence Center. And the idea is to get access to every piece of health data, especially public health data, but they also do have access to personal health information, and use that information to make better informed decisions at the national level. So you can imagine all the EHRs, there are like 7, some of them implemented by government facilities, some of them implemented by private, some of them by faith-based organizations. So it's a competitive market. But then how do you build interoperability between them so that this data is accessible in ways that are privacy preserving? So that is understood. But access to that data is there. And then there are systems to manage dispatch of ambulances in the country, for example. There are there are reporting systems for those who are aware of something called DHIS2. All those systems are there. Previously, the data was scattered and nobody could make sense of what's going on. Who can feel the pulse of the country when it comes to health? It was not possible. But today, it is possible. And it's convergence because not just the technical convergence to collect data and analyze data, but now we realize that the first use case that was implemented was the ability for the Minister of Health to ask a question to the AI model. I've got $1 million. What would be the best use of this money to improve health outcomes in the country? Is it to build a new bricks and mortar facility? Is it to scale up the implementation of the EHR? Is it to hire a couple of more doctors or nurses? What is it? So for the first time, the Minister of Health has a tool that allows him to check, make such kind of a decision. And then when it's building a health facility, then you can ask the question, where does it make the most sense to build that facility? Where the demand is highest, the need is highest, or the ability for people to pay is highest, where there is a road, accessibility or connectivity or whatever, using all sorts of criteria. So, and that is really a convergence in terms of a system that brings data together from multiple systems, but also starts serving economic needs, economic use cases. And then the science comes also behind that because with all this data and AI, most evidently, the decisions or the insights that are going to be generated are science-based. So that's one example. The second example, quickly, is something that is happening in Kenya, and it's really phenomenal. So Kenya is setting up something called the National Digital Health Superhighway. And it's a first in Africa. And the idea is to, again, connect, first of all, digitize everything. So digitize from the communities. Community health workers have mobile phones, so all these, at the point of care, information is available in digital format from the start. All this information is now available. And then digitize insurance everybody has access to insurance. They can pay their insurance using the airtime, pay a cent every day, and it's automatic. So affordability is built into the superhighway. But then there is the shared health record and everything that comes on the back of that digital infrastructure. So convergence is happening, and from one country doing the National Health Intelligence Center, 18 countries are now starting on their projects. I'm really encouraging more countries to go the national superhighway. So convergence, and the interesting thing to close, one of the companies building the national superhighway in Kenya is called Convergence. The three companies, one is the largest MNO, it's called Safaricom. The second is the one building the middleware, it's called Convergence. And it carries that name for the last 15 years, so they didn't copy this. And then the last company is a company that came from UAE, to the global health connection. It came with technology and money to build this. So convergence is the way to go, and it's happening.
Well, I did ask for specific examples, and Phil, as usual, delivers. So thank you for that. We'll come back to you in a moment. Just to let you know that in addition to the virtual audience, which I think we've got a voice in the room, have we, Bleden, for the virtual audience? Because I worry always when we've got so many people online that you sit there, we've all done this, and you're watching, you get all sorts of, I don't agree with that, or whatever you want to say. And what happens is you type into the chat and nothing happens. So today we have decided, and yesterday we did, appoint someone of our team to watch and monitor those and intervene as a questioner from the audience, but on behalf of the virtual audience. I was told yesterday someone's already stolen that idea and is going to use it at all of their events in future, but so what? So we weren't able to patent it, so I'm sorry, we just had to give it up. We have two speakers also online. Another one of our speakers, I know, is stuck in traffic. I don't think it's possible to get her connected in to do it from the cab. We'll see if she turns up. But in the meantime, we've got two of our audience, or our participants online. One of them is someone we know very well from my home city, I should tell you, of Belfast, which I'm very proud. Adrian Johnston, who's the Innovation Commissioner for Belfast. He has some specific things to talk about on convergence, so welcome, Adrian. David, if you from Scotland, as an example, to give us on convergence as well. Are we ready with David's slides as well? Can he? David, do you want? I know it's a bit of a shock, but would you?
Yeah, it's probably easier if I share, isn't it? And then I can drive. It probably makes life a lot easier.
Yep. Only a couple of minutes as usual, because we conceded you could have slides, but
yeah.
No one else has.
Can you see those? Yeah,
yes,
I thought it. This is sort of quite a complex area, and so I thought it made sense just to share just a few pictures. And first of all, thank you very much for asking me to speak, and also my apologies for not being there in person. I'm sort of really interested to speak to you today about the work that we're doing through Aim for All in the data field, but also Remedium Capital in the field of innovative finance. And yes, we've had to bring those two initiatives together in order to make the sort of the innovative financing thinking a reality. Just in terms of my background, I'm a corporate financier by training. Much of my career has been spent exploring alternative financing models, especially in areas like research and development, where there's an opportunity to think beyond traditional approaches. My interest in this space actually began on a very personal note. My wife was diagnosed with cancer, and that experience fundamentally changed how I viewed healthcare access, especially around the challenges of evidence generation, pricing, and how we might bring new innovative treatments to patients. And as I started digging into that area, one thing became very clear, and that was that there was a very real opportunity for risk capital insurance-based products to help facilitate market access. And I guess since that time, the rationale for using sort of insurance-based models in this space has only become stronger, especially in the new sort of US era of global price benchmarking. Now, we're all operating in a world where the economics of drug development are becoming more complex. Development costs are rising. Therapies are increasingly delivered as part of complex service models, and in many cases, critical world data, real world data, only begins to emerge after a product has actually been launched. We're living in a world where an increasing proportion of novel therapies is available to a decreasing proportion of the population. And this is an industrial scale challenge that's simply just not going to go away by itself. Now, in that context, we see two immediate opportunities for innovative financing to play a role. First, in emerging markets where underwriting outcomes can help expand access to more affluent patients who are willing and able to self-pay, but only if a treatment works. And secondly, in developed markets where underwriting pricing can help accelerate negotiations and enable faster market access, especially in cases where there's still some uncertainty around real-world effectiveness and performance. But of course, we can only underwrite risk if we can robustly measure outcomes. And that brings us to the sort of the big data challenge, which we've been tackling through the AIM for All initiative, the Access to Innovative Medicines for All initiative, in collaboration with Scottish Government and more recently the UK Advanced Therapy Treatment Centre network. And together we've developed a sort of a proof of concept data governance framework and digital solution, which has been built to capture pre-agreed data sets covering both the HR, PROMs and other data sources, importantly in real time, but more importantly as part of routine clinical practice. And from a financing perspective, we've demonstrated how this data can be automatically read by an external contract management platform and used to power a suite of insurable outcomes-based contracts. In other words, what we're doing here is we're building the data landscape backbone to make this kind of thinking and these kinds of financial models operational and not just sort of theoretical. So I don't want to go into all of the detail of that today. You know, we certainly don't have time to do that. But I just wanted to sort of touch on some of the key principles around the sort of the innovative financing work that we've been doing. And the first part here is that, you know, if we're going to deploy insurance-like products in this space, they need to be structured cost effectively and crucially in a way that aligns with the level of risk that's involved. And if we take a sort of a common scenario, which I sort of illustrated here, a product which is launching with an emergent data set where real world evidence is still needed to determine its true value, and we don't want to have a big debate on how we value something today. But in this case, the product's worth is likely to fall somewhere between a plausible maximum and a plausible minimum. Now, the lower end of this journey, the lower end of this range naturally carries less risk than the higher end. And so ensuring that proportion, this lower proportion of risk, is cheaper than ensuring the higher end where more uncertainty exists. And this creates a really interesting opportunity to structure cost effectively. You know, we can optimize an underwritten price that reflects the manufacturer's financial needs, factoring into account not just that manufacturer's cost of capital, but also set against cash flow considerations and other commercial needs. Now, the elephant in the room is why on earth would a manufacturer not just sort of self-insure? And well, as with most things, it really depends. And there are two factors in particular to consider here. First of all, a manufacturer's need for immediate cash flow, which can be especially pressing for early stage or emerging companies. And so smaller companies are more likely to reach out for these sorts of financial innovations than much larger companies. Secondly, however, is how these insurance-like products are actually structured. And here I've tried to present sort of a couple of models. The first model is where a payer pays the launch price to the manufacturer, and the manufacturer enters into some form of insurance arrangement in return for a sort of a higher underwritten price, which translates directly into a higher cash flow and downside protection. The second model is where the payer insures against the launch price with an independent party and pays the underwritten price to the manufacturer. And again, with impact on cash flow and downside protection. Now, in both of these cases, the cost of delivering that insurance and the cash flow consequences and the downside protection is exactly the same, but the commercial impact is very different. So Model A results in a lower reference price and lower near-term earnings, whereas Model B, on the other hand, delivers a higher reference price, which is of particular interest in today's environment, and higher near-term earnings, which is a much more commercially attractive sort of solution. So just on these 2 pages, I've just tried to give you a flavor of some of the innovative financing work we're doing. Innovative financing isn't a one-size-fits-all. If it's allowed in the room during these sort of reimbursement and pricing discussions, it can be optimized to really depending upon a manufacturer's economic and commercial needs. So where are we in terms of this being real work that's taking place? On the data side, our work through AIM for All is now moving into a live environment, and we're actively engaging with manufacturer partners around real-world data use cases. And on the financing side, the remedium thinking has been fully diligenced both by health systems and manufacturers. And we're now essentially waiting for the data infrastructure piece to fully mature before we can take this work into practice. So just a bit of a flavor of what we've been up to in terms of actually learning by doing rather than by talking about things. I'd be delighted if there's anything that resonates here with any of your audience. We'd be obviously delighted to speak further. Thank you.
Thanks very much, David. This is a good example of where there are, again, what we said earlier, there are people thinking about and doing some of these things around the world, but they're not necessarily connected to specific opportunities or projects. And I think that's what this session is already illustrating. So thank you very much, David. What I'm going to do to make sure the speakers have at least 1 minute warning of when they're going to speak is, Adrian, if you can hold on. I know it's not that late. You'll have to go and get your dinner soon in Belfast. But if you could hold on for just a few minutes, because I'm sure you're enjoying the interchange anyway. What I'd like to do is to come to our partner from GSMA to follow up effectively on also what Phil was saying, because Safari, as I understand it, are one of your members in Africa, of course. And there's one of your members actively involved in effectively a Convergence project. So would you like to give your... Is it working? Sometimes it's a 1 in 3 chance of a microphone. There it is. Use that one.
Thank you. Thank you very much. Thank you, Brian, and good morning, dear colleagues. As mentioned, my name is Caroline Bugwa. I'm Senior Director, Public Policy and Communications at the GSMA, covering the Africa region. And it's interesting what my colleagues have talked about, because convergence is something that we're pushing very hard in Africa. And this is because we continue to experience a significant gap in terms of healthcare, universal healthcare, and of course also trying to drive general, because if you look about economic development, that's impossible when you don't have a healthy community, if you don't have a healthy population. And unfortunately, some of the statistics confirm over 615 million Africans don't have access to proper healthcare. So the way we look at it at the GSMA is really and truly the connector of all this is technology. Because at the end of the day, you cannot talk about convergence without talking about connectivity. Because technology is what provides you, because for you to have that convergence, you need information. And technology is what facilitates information to move around. So we track how this is evolving in Africa, particularly, which is what the area that I'm covering. And so this provides us with the insights that we need to be able to support these decisions that are required to drive convergence. Now, when we talk about connectivity, there are a couple of areas that we monitor. So, of course, we look at those who are connected to the internet and those who are not. Because we all know the benefits of internet connectivity. I will not belabor that. Because when you're talking about digitizing, like what John Philbert has just talked about now, building the digital superhighway, is essentially leveraging technology to harness data collection that can support decision making that is being done by as he mentioned, Safaricom, a few other partners, and the government of Kenya. So we start by ensuring that we have the right infrastructure in place to support convergence, because technology provides the first layer, then we build on it the other services such as digital health, digital financing, and so on and so forth. So from our research as GSMA, we've identified that the number of population that is connected to the internet in Africa is just about 30%. Yeah? So these are subscribers that are constantly using internet connectivity, and I would say these are unique subscribers. 59% have access to this service but are not using it for different reasons. And the main reasons being the barriers in terms of affordability, digital literacy, relevant content, and so on and so forth. And we've got about 11% that are not covered at all, don't have any signal of connectivity. So if we are talking about convergence, we must first find what is that addressable market. Because for someone to be motivated to actually be considering convergence, they must understand what's the size of the pie if someone is to invest. Yeah. Now, we even break down these numbers further to understand, because we know for us to be able to move at the speed we are supposed to, we have to rely on high speed, low latency technology, so more advanced technologies. So this is the 4G, 5G, and so on and so forth. So we break it down a bit further and say, out of the number of connected, we have a whole 14% that is still on 2G. So we all know what 2G connectivity is. This is in Africa. So 2G connectivity just allows us to do call and message. Yeah. So we have some solutions that have been built that use USSD that can support digital health. Yeah. But there are limitations to it because, of course, there's only so much you can do by sending an SMS and so on and so forth, although there are solutions like that. MTBA, for example, is one of those in Kenya. Now, out of that, now we see another 49% using 3G. 3G as a technology is inefficient and doesn't provide the necessary features that we need to be able to drive the digitalization of economies. And then we see out of that 35% are on 4G and only 1% is on 5G. So we need to address the key barriers of convergence, and number one being infrastructure. There has to be the right policy in place. And for that to be successful convergence, there has to be a national approach to it. So governments have to sit and develop a national development strategy that embodies or it has some of these as the key pillars. So driving infrastructure is very, very critical. So once you have addressed the pillar of infrastructure, now you move on to the other barrier, which is interoperability, which is what now is being, a good example as Adrian and Philbert has talked about in Kenya and Rwanda. That's exactly what these solutions are trying to address. The interoperability of systems to be able to exchange information and for be able to have your data as a patient readily available and can move between providers, to be able to improve your diagnosis, your treatment, and so on and so forth. But for that to happen, again, policy has to step in because you have to have the right laws in place to be able to support and provide guidance on how this data is collected, processed, and how the rights of the data subjects are continued to be protected over time. And so, and in terms of exchange of information and cross-border flow of information. So this is an area, again, that we see a big gap because for you to make sense of this data, there has to be the supporting policies to be able to support you to develop and process the data into actionable insights. At the GSMA, we've built a tool that we are calling the Digital Africa Index. So the Digital Africa Index is supposed to support with that exactly. It's a web tool platform, and it provides information of the level of digitalization. So we moved away from counting connections to seeing how progressed is an economy in a particular country from the digitalization perspective. So looking at three pillars. So the consumer being one of them, government and business. So essentially we are tracking to see what is the level of digitalization of these three key pillars to be able to now drive, because if you're talking about convergence, if you don't have these consumers readily available to be able to understand that, then it becomes very difficult. Yeah. We have also worked on what you're talking about, digitalization reports. And these digitalization reports help us understand at a market level what is the impact of driving the adoption of technology in different sectors. So healthcare, finance, transport, and so on and so forth. And we have seen a significant impact in terms of the accelerator. Because we say for every 10% increase in adoption of mobile broadband services, we see an up to 2.5% jump in GDP growth. So the value is there. So essentially, what you are just trying to say, without digitalization of economies, we will not achieve convergence. Because that is now what connects all these sectors, provides the necessary information for us to be able to address a particular challenge. I'll give an example. Before joining the GSMA, I worked for a mobile operator in Kenya. And as part of my duty, I was in charge of what we call the Universal Service Fund projects that were delivered by the regulator at the time. At one of the times when we were launching one of these universal service sites, and majority of these sites are rolled out in rural and hard-to-reach areas. One of the ladies that made a speech on that day, she's a midwife in that area, and she said before they got that site up, 3 out of 10 women died during childbirth. It's a basic necessity to ensure that that is covered. 3 out of 10 women died during childbirth. But since the site was put up, the numbers have significantly reduced because they're able to access the healthcare that they need. They're able to get the support that they need. So if we look at the entire ecosystem, access to a doctor, access to an ambulance, access to information, you're able to do that. Another example is we partnered with a university in Singapore with a doctor. His name is Dr. Gao. And he and his team were testing holomedicine in deep rural of Ghana, an area called Kumasi. And what they did is leveraging technology, and in this case, they are using just 4G. Yeah, so not 5G, and we all know the benefits of 5G. High speeds, low latency. So meaning, if you're to do any technologically driven solution, such as holomedicine, you stand a better chance of greater success with 5G. So in this case, they were doing it on 4G. And they were able to support surgical procedures from Singapore provided in Ghana. So what that means, you cut the expense of having to go all the way to Singapore, for example, or we address the challenge, the knowledge gap that we have, and ensuring that very highly experienced doctors are available to provide surgical services in Ghana. So this is what Convergence can do, but we can't, like I said before, we cannot be able to do that without leveraging technology. So the first step is addressing how well is our digital infrastructure positioned, what is the level of adoption, what are the policies in place to support the cross-pollination between different sectors, and that will need to be driven at a national level by government to now providing that enabling environment. Because a lot of the challenges we face, like you mentioned, you go to these rooms and people are talking about different things, is because they are not talking to each other. So that national strategy of digitalization is critical, that now cascades to other things such as digital literacy of healthcare providers that is necessary in driving convergence in this sector. Thanks.
Thank you very much. I mean, that was a great example of a couple of things. A, very informative, but secondly also, this does affect real people and real lives. You know, this is not about some, wouldn't it be wonderful to have this technology or this ability to communicate? This is not only about communication. This is about literally transforming and saving lives. So we should remember that this is not an exercise in our minds or on a whiteboard, as they used to be whiteboards, by the way. I remember that from my earlier days. But now, we need to remember this is a human impact thing as well. So thank you very much for that for the moment. What I'm going to do, with your indulgence, Raj, because I know you sat very quietly, but I spent 3 days with Raj in Mumbai over the weekend, and I've been on a 16-hour flight with him as well. So I'm going to ask him to wait a few minutes longer before we have another chat. So maybe we bring you in, Adrian, if I could, from the city of Belfast, the proud city of Belfast. Off you go.
Thanks, Brian. Thank you very much for the invitation to join you all today. Apologies I can't be there in person, but I really value the opportunity to talk to you. As delighted that I'm actually following Angela from GSMA, Brian, because she talked about the need of convergence of all aspects of the ecosystem. And my role as Innovation Commissioner in Belfast is to develop that strategic alignment across the full innovation landscape, so that between academic institutions, public services and government, communities and industry, and if you like, that quadruple helix, and how we bring those partnerships together. Now, one of the barriers that you will have from doing that is obviously funding. And one of the huge enablers that we have in Belfast is the Belfast Region City Deal Investments, which is a co-investment by the UK government and the Northern Ireland Executive, the Northern Ireland government. And that's £1 billion of investment in the Belfast region over the next decade. Now, when you look at the split up of that investment, it's about £350 million of investment in research centres of excellence, ranging from advanced manufacturing to indeed health and life sciences. And I believe you might have our friend Mark Lawler, Professor Mark Lawler, in the room. And Mark would be a principal investigator of Momentum 10 and engaged with iReach, which are two health and life science-based programs as part of that City Deal investment, looking at data-driven clinical trials and also longitudinal studies of health data. We also have Connected Data Health Technologies, which is run by Ulster University, which is looking at health technology connected to citizens to improve health outcomes. Now, it's all well and good having that research capability, I suppose, at our disposal between our academic institutions. But as Angela said, we need to drive the right policy and procurement environment for government to look at the potential need and how to procure those technologies. And that's part of my role. And how I do that is through £120 million of funding, looking at stimulating that ecosystem broadly around a mission approach. So we know what our strengths are. We know where some of our barriers in terms of procurement and deployment might be. But one of the glaringly obvious issues that were missing from that ecosystem was need, and that need which was co-designed with citizens, and how you bring citizens very much into the design of that process. Now, we've ran a number of different pilots, if you like, over a number of years, looking at that and looking at the community infrastructure that exists in Belfast and the broader region. For example, Homes for Healthy Ageing, which was a partnership between Ulster University, Queen's University, the Public Health Agency in Northern Ireland, Belfast City Council, which is the civic leader, of course, within the Belfast City region, and looked at and community organisations, and looked at a way of developing technology which would assist older residents within Belfast to stay in their homes longer, connected to health provision, reduce isolation, but also look at the very intangible pieces of building trust amongst communities about how their data would be used, and therefore how could we scale those initiatives in the long term. And that's what we're doing now. We're looking at how can we scale those initiatives in terms of Belfast used as a living lab. And that's effectively where we're getting to at this moment in time. So we have data. Angela talks about data. One of the advantages that we have, and one of the case studies that we have, Brian, as you know, is that we have an integrated health and social care system in Northern Ireland. One single system, which is bringing unification of that data. There's 1.9 million people in Northern Ireland. Over half of those residents live within the greater Belfast region, of which we will be deploying this technology as a living lab. So we have a population size which is relevant for trials of policy, of technology, of interactions, and that environment that Angela just talked about. We also have what's called the Northern Ireland Honest Broker Service, which allows researchers within our academic institutions to apply and get access to healthcare records, anonymous healthcare records, which allows clinicians and researchers in Momentum 1.0, in Connected Data Health Technology Research Centre and iReach to get access to some of that data. But what we want to do is to scale that again through this mission-based approach of better health outcomes for citizens. So we look at the IT systems, and we're going through that digital transformation of IT systems. Connectivity, again, as Angela mentioned, is a huge issue. And what I'm looking at in terms of our digital pillar funds of £120 million is taking some of that investment and looking at connectivity, both in rural innovation, urban innovation, and also looking at connectivity within clinical settings and how that data can be used to augment the data that we already have in our integrated care system, not just with GP records, but starting to look at the social data, looking at how technology is being used and how it's being developed, and fundamentally how it's starting to improve the outcomes of the citizens and the people that will be using that technology. Fundamentally, where we want to get to this approach is unifying that digital infrastructure, if you like, looking at have one longitudinal data set that our researchers can use to drive better policy, more informed policy, but also ultimately drive better procurement of technology and ultimately improve the health outcomes of our citizens. One of the things we also look at, we've done small pilots, but how do we look at strengthening our data governance, I suppose, in terms of that trust, that public trust? How do we ensure that data is being used ethically, but also how do we ensure that technology is being responsibly developed? And that's the importance of bringing industry in to look at how they can co-design these products with the public, how we can translate some of that research into real tangible processes and product innovation, and drive up more responsible and ethical development of that technology as well. So we're ultimately seeing Belfast now as a living laboratory of data, of use cases to improve those health outcomes. I suppose I'd leave it at this point, Brian, by saying the big challenge that we have and the convergence that we're starting to see in this is that, yes, we have the data and we're starting to augment more on that. Yes, we have the technology and the research capabilities of which we can continue to develop. But one of the big issues is around that deployment. So the processes, the system, and the culture of that deployment. In an innovative world, you need innovative industries to take risk. In health and in public service transformation, risk is actually governed out of the innovation. So one of the things that we're looking at is how can we look at these test beds, how can we look at developing these, and how can we provide the culture change, the skills and development change, and the innovation change within public sector transformation to enable these technologies to be utilised. So it's a very exciting time for us in Belfast and developing that strategy. And ultimately we want to see and market Northern Ireland really as that population laboratory that can be used for the convergence of the quadruple helix and improving the health outcomes for our citizens.
Thanks very much, Adrian. And Adrian and the City Hall worked very. In fact, we had a meeting actually in the City Hall of Belfast, just one of our ecosystem meetings just a couple of weeks ago, and we had a great demonstration or showcasing of the capabilities in Northern Ireland, but the concern that we need to move faster. At least we've got a bit of money now, and we are trying to lift Northern Ireland out as an example around the world through the global health connector. So thank you for that. Welcome our speaker who's managed to get out of a taxi and get here. I'll give you time to catch your breath. But would now like to move from Northern Ireland, Africa, etc., to India. And we have Raj here. Do you want to respond in terms of this whole topic of convergence, Raj, please? Please.
Thank you, Brian, and the Global Health Connector. I'm always impressed by the topics we pick, but I can connect to this topic more than anyone else. I wrote the election manifesto of our current Prime Minister in 2014, writing policies for all sectors. Besides that, I also wrote the policies on health. I was advisor to the Health Minister for 3 years, education and economy. I would flip the question, keeping the words, what is convergence? I will say convergence for what? That's important. If you look at all the economic policies, they miss one word, and that's productivity. If you do not converge for productivity, you do not get what you want from economy. That means you have to go back to health. That's one. And also, I besides writing policies in India, I also chaired 3 committees at the Internet Governance Forum. And those who work in this area, you know that this is a specialized body of United Nations. The committees I chair are digital health, digital economy, and environment. Having said that, I think since the topic is obesity, and very rightly picked up Brian, obesity I would call is a physiological manifestation of a leadership and a systemic failure. And that failure is across science, that failure is across urban design, infrastructure, education, policy making, bureaucracy, and parenting. Is not just one area. We know 1 out of 8 people are obese, and this is when we're going to hit half of the people being obese by 2050. But what is more concerning is that this is a situation when 1 out of 8 are still not even connected to the internet, or rather 3 out of 8, right, in the system that we have. And obesity, I call, is a master disorder. It leads to many more disorders. More than a decade and a half, I was advising HAD, their CEO was with me, and I said, in the UAE, you have 66% of the people who eat red meat and are obese. What do you do to them? So we created programs for obesity starting. He wanted 6 programs to be rolled out in one go. I said, no, I don't know the formula for success. I certainly know the formula for failure. If you roll out all programs, we are done. Start with obesity. So that's been something that I have looked at. And now let's get to the cause of why this will still continue to be a big problem. The answer lies in how we look at health systems, how we look at health. More than 10 years ago, I gave a TED talk at NUS Singapore. That was on a term that I coined for healthcare called preemptive care. That time that was not used for health. The idea was to preempt the occurrence of diseases. And the fundamental question that we all have to look at, what do we measure for health? Number of doctors to population, nurses to population, beds to population, and what this is all about, prescriptions and admissions. We are not looking at health. You will only get what you measure, and we are measuring sickness. So if the entire world health system is measuring sickness, you will build more beds, you build more hospitals, you'll get more nurses, you'll get more doctors. So result will be more prescriptions and more hospitalization, nothing else. So if you're even looking at obesity, that time I suggested we need to look at gyms to population, jogging tracks to population, meditation centers to population, yoga centers to population, because our yardstick for measuring is what? Any country you will measure in terms of morbidities and mortality. You will get that more because that gets rewarded. So I think everyone starts talking of the economic impact and finally trying to find commercial solutions, which is not bad, but then our approach is wrong. Having said that, I was addressing the Chief Minister and the entire cabinet of the state of Chhattisgarh, which is 30 million. Any state in India is more than the population of few countries. And I told them that can we implement a program 4, 14, and 40, because these are the ages you can bring a change, reverse it. And that's implemented. We're going to see what the results are. The minister told me over dinner, sir, I have implemented the suggestion that you said. So we need to start thinking very differently and not go by the playbook that we have had. I have full regard for WHO and the UN system, but we are repeating the failures and building on that. Brian was with me in Mumbai, and our first session was fixing a broken health system. If you keep building on the broken health system, you're going to build a bigger broken health system. And that's exactly what we are doing. I think we need to change that. And we keep bashing individuals. Please take care of your health. I did research. It's there on the blog of parliament.health if you go. And the numbers are like this. 20% is inheritance and genetics. I have no role in that. I acquire illness because of that, or sickness. Food systems, 20%. Environment, more than 24%. Clinical care, 10 to 20%. So actually, I am individually responsible for just 10 to 15% of what I suffer or pass through. Why keep bashing me, take care of your health? When there are so many things, so convergence for me is important. Convergence for what, rather than what is convergence? And I would say that we all need to do a reset. I think Bladen was asking a question that what has been invented and what we do not need to reinvent. I think probably everything. That's where we started this Global Health Summit a couple of years ago, saying the golden age of medicine is still to come. We are not yet there. And that means you have to reset everything, starting our thinking, which is terribly wrong and misplaced. I'll stop here, Brian, and thanks for making me sit for long. I did the same to you. That's good of working with politicians.
Instead of just, even though I spent 3 days with them, I've heard, I learned something new again about Raj today. So let's keep moving on. The cabs in New York deliver eventually. So unite this group have joined us now. So please, do you want to speak there, or do you want to please go ahead?
Good morning, and my apologies for being late due to the cross-city closure, and it was really difficult to reach the venue. But I would like to start with thanks to the organizers and conveners of this important event, because starting dialogue on convergence is extremely important. Of course, we know that health, economy, finance, and science and technology are very closely interconnected, and none of that can work in isolation. Just to remind us of the few facts that health systems comprise 10% of the global GDP. Health contributes to 5% of the global carbon footprint, and every dollar invested in healthcare results in $4 return on investments in economy. So good health is good economics. And we were the witness of this convergence in action when the pandemic hit. We saw how the 10 years of economic gains were lost in just a few months because of the COVID-19 impact on health, welfare, our daily lives, and the economic declines. However, what we don't know, and we don't have a lot of examples, is how to make the convergence happen effectively in action. As the health sector policymakers, we're not even really efficient in integrated, holistic strategic planning for health sectors that can really ensure universal access to healthcare and the best cost-efficient and evidence-based planning for the health sector impact. Yet when we speak about converging and connecting health, finance, and economic sectors, it's even more complicated. Do we really have any tools to facilitate decision makers in connecting those dialogue? Yes, we have some successful cases of ministers of health, of ministers of finance speaking about investments for immunization, for HIV/AIDS, for universal health coverage, but we don't have the tools that policymakers can really apply in their daily decision making. And taking an example of any politician that has to deal with multiplicity of problems in his or her electorate, we really have to help them to make those convergence happen easier. RNA, the regulatory impact investments, was a very interesting tool, but it was never applied systematically or regularly among parliaments or the health sectors. One Health tool is an excellent example of the attempt to really strategize and universalize the health investments for health. And after millions of dollars invested in the tool, do countries really use those tools? So my call would be, yes, let us highlight that health cannot be effective without proper funding, proper economic backup, proper technology and innovations investments, but let us work to create AI-based technologies that can help policymakers in better decision-making and reduce the error of human decision-making, because we have lots of missed opportunities in decision-making. So every minister taking the office is trying to do something new and not really build on the successes of the others. So thank you very much, and I would like to leave some time for the Q&A. Thank you.
Well, what we managed to do, I think, is go around the world in faster than I normally go around the world, and we at least have snapshots from many countries, many continents, in fact. So thanks to all the speakers. I'm looking around to see if we've got some virtual. They're looking at the monitor for the 500 plus people or whatever it is listening to us at the moment. So you need to be on your best behaviour in case you say something you shouldn't. So let me begin. I'm trying to. Who is the voice of the virtual? You are. Right, go ahead, Heather.
Okay, so I have a question coming in from Queen's University in Canada, not Belfast. And it's about funding, saying that researchers are willing and collaborating, but lack of funding to complete their work. But with NIH now basically gone, what other opportunities are available?
Okay, we'll come back to give me a few, when you've got a few other, okay? So you're going to look at the monitor again. Funding's always a big thing. I've got my own views on funding because too often people, I think, spend their entire lives chasing after funding, one funding after another funding after another funding. And I keep wondering whether there's a point at which you say, when are you ever going to be sustainable yourselves? But that's my personal view. I'm sure particularly researchers wouldn't agree with me. So I've got time then to hear from the audience. So any questions from people in the room then? Happy to take any question you want. Please. Then.
Being built.
Please, I didn't hear you. Please.
Oh, yeah. Yes. So, yeah, it's Mina Abadir. I've been worked in 11 with Tom Pharma, but now helping AI, with AI and other systems. Just for the questions for Jean is in terms of the superhighway that was being built or has been built. How do you integrate all the systems together? Even from paper records, has that on, because that's a big challenge to integrate the systems and then to have people really, these hospital systems or clinicians use them across the board.
Thank you. Anyone want to respond to that? You've got your microphones there, I think.
Yeah. Quickly, thanks for the question. We can even have a longer discussion after this. But the focus has not been on digitizing paper records because that's almost like the legacy. But the government has rolled out a new electronic medical record that covers all the public health facilities. So it's fully implemented. It's called Tibabu. It's done by Convergence. And that ensures that at least the medical records that are being generated today are digital. So the question becomes, what do you make of the legacy of all this health data that is trapped into paper? Now, Kenya has had a great record digitizing the historic information, historic data in certain sectors. In the justice sector, it was done. In the media sector, they have digitized all the newspapers that have been produced since independence. There was a nice project supported by Google to sort of scan for hate speech and stuff like that. So I don't think it's inconceivable that at some point there will be an initiative to digitize historic medical records for all sorts of reasons. Maybe there is even a business case in doing that. But I'm not aware, and I may not be on top of the latest developments because I'm based in Rwanda. I'm not based in Kenya. But if you have any idea of what could be done to digitalize all this historic information, it will be welcome, especially if there could be a business model behind it. I know Ghana is doing it for US. India is doing a lot of medical transcription for the rest of the world. So there is something that could be done there for Africa. Happy to pick up the conversation after.
Okay, I'll take that offline then, okay? Anybody else from the panel want to comment?
I like to answer the question on financing. We always think of health, we think of finance. I think start moving the needle to collaboration. It's not just about money. You're just chasing money. You're not chasing outcomes. So please move the discussion from just looking at funding and all. Despite all the funding, where are we headed? So I think collaboration is more important than money. Thank you.
Interesting comment. Anyone else in the audience? Sorry, the lights are a bit. Any other questions in the audience? Sorry, please, go ahead. You got your microphone.
Thank you. Thank you very much. Thanks, Philbert, and thanks for the question. I just wanted to add on a bit more. seeing that I come from Kenya, I'm based in Kenya myself. One of the strategies the government has employed right now is to drive the adoption of internet services in all public healthcare facilities. And this is now to support with that digitalization that we are talking about and seeing how now they can start to do automation of all records. And I know that it's a project that is being pushed between the Ministry of ICT and the Ministry of Health. And there are pilots that are currently ongoing to see how that can be able to be scaled across the other parts of the country. But like Philbert mentioned, I think it's clear that the historical issue will require a bit of rethinking to be able to address that particular information. But what I see valuable is if you're able to get the information, your information from now going forward digitally, it means that because right now you're not able to move around with your information from one provider to another. If you'd have to go and get all your tests and everything done, from scratch for you to be able to seek treatment, which takes time and sometimes misdiagnosis and so on and so forth. So it is a project that the government is trying to look at, but I don't believe it's a key focus right now. The main focus is how do we fix this problem going forward, which I think by doing that we'll have addressed about 70% of the issue. Thanks.
Thank you. Please go ahead.
So I would also like to add some of the examples from my country, Georgia. I was serving as the Vice Minister of Health when we launched the universal health coverage, and then the Member of Parliament and the Chair of the Education and Science Committee. So first of all, I completely agree that it's not about funding only, but efficiency of using the funding, planning ahead for the best possible utilization and value of the resources, and definitely sustainability. 12 years ago, when more than half of our population had no access to basic health care, due to inclusion of the UHC in the political manifesto of the current ruling party, the government actually doubled the health sector budget in 2013. And we even allocated money from the different sectors, including military. And collaboration of finance and economic sectors were vital in making those decisions. And today, every citizen has the basic package of UHC at primary, emergency, or hospital levels. Not everything is ideal, but given the limited resources of the country, it is possible. As for the sustainability, we have seen that international aid has, of course, scaled up important achievements. We would never be able to attain health-related Millennium Development Goals or currently some of the targets of the Sustainable Development Goals without the Gavi, Global Fund, UNITAID, or B and multilateral donors. But when the countries are no more eligible for international aid, that's where the sustainability challenge emerges. So planning for resource mobilization should be, of course, in line with the withdrawal, like a donor withdrawal strategies as well. And this was also successfully done for immunization programs, for example, starting from UNICEF, continuing to Gavi. But definitely it's all about strategizing and planning.
Thank you. I know we've only got about 3 or 4 minutes left. We have a speaker in the room. I can just see you through the light. Sorry.
Yes,
Please.
so thank you so much. My name is Dr. Katarzyna, and I work as an expert advisor evaluator for European Commission. I'm an expert in innovation in healthcare, generally speaking. My question would be maybe a little bit controversial in a certain way. I have asked this question in 2011 on a conference which was uniting people from around the world. And I ask this question again because I haven't seen really a progress. Do you think we are able to come to a realization of creating a unified global healthcare records, where actually patients will be able, while traveling, have access to their data, have access to being able to go to the healthcare providers if something happens to them when they're travel, when they're in another country, when they are, in a situation when they need to leave their country for any reason, including migration. And what would you feel if that would be something doable in the future, which could actually bring, a lot of topics to go beyond discrimination and a lot of discrepancies in the healthcare? And what would be the biggest challenges in that? Thank you.
Okay, we'll take that in a second. I know the problem is we've got a question to another, but we want to bring some of the online audience in as well, if you don't mind. So we've only got 2 minutes left. Heather, have you got another question there from online?
Yeah. It says, we need AI tech to treat diseases and analyse and run health programmes. However, are we paying enough attention to the changing behaviour of the population?
Interesting. We could debate that forever. I know I haven't given much time to all the speakers to get involved, and I apologise for that, but we're running out of time. Raj, do you want to quickly respond to that point was made by the lady from the European Commission?
Yeah, so addressing that, we on 19th May on the sidelines of the World Health Assembly launched Digital Health Sans Borders, that we should not keep appreciating technology but help save lives with that. And one of the themes is what you talk, which is very timely. Thank you.
The only thing, if I may respond to this, I'm old enough to remember the approach by some people to try to have a global language. I think it was called Esperanto. All of you who are in the audience who are much younger will not remember that, but it's true. It never really took off. My worry with all these things is they always take 25 years to consult on, to write reports on, and in the meantime, people are dying, people are getting sicker. So in the meantime, you've got to do things in parallel, not sequences, is my quick summary. Phil, do you want to respond to that question about not just the global thing, but this whole question of this, finally on the convergence, we keep hearing about ministries of this, ministries of that. Do you feel there's any convergence of the ministerial level at health, economy, etc., or is that just one department to another?
It's happening, but it's way too slow to my liking. But we have to continue because that's the only way. And sorry for the 15-year question that remains unanswered even today. The World Health Organization launched something called the Global Health Data Certification Network that is supposed to answer that. I don't think it is actually answering it. I think this can only be solved by the private sector. I'm sorry, not governments.
Yeah. Now, I know everybody wants to speak, but you can't. I apologise. I've never thought of myself as a dictator, but in this case, that says stop talking. So if I could, I'd just ask you all, please, to thank the speakers, both online and here.